Good evening, ladies and gentlemen. For those that don't know me, I'm Alistair Burt. I'm the Executive Dean of the Faculty of Health and Medical Sciences. It's great to see you here this evening. I'd like to start by acknowledging the Ghana people, the original custodians of the Adelaide Plains, and the land on which the university's premises in North Terrace, Waite, Pemberton and Roseworthy are built. Earlier this month, there was Dying to Know Day, and we felt then it was apt that tonight we would invite and hear from Professor David Currow on his work in palliative care and the need for all Australians to begin a conversation with their loved ones about their future wishes for care. David is Professor of Palliative Medicine at the University of Technology, Sydney, but also the Matthews Flinders Distinguished Professor of Palliative and Supportive Care at Flinders University. In fact, you'll see it all up here, and you'll see astonishing a third position at the University of Hull in England. His research includes clinical trials and the use of large data sets to better understand the impact of life-limiting illnesses on patients and caregivers. Research into chronic breathlessness is a particular area of expertise. He's the Principal Investigator for the Australian National Palliative Care Clinical Studies Collaborative and a Foundation Partner in the Australian Palliative Care Outcomes Collaborative, an initiative to improve palliative care clinical outcomes. He's published more than 500 peer-reviewed articles, editorials and books, and is Senior Associate Editor of the Journal of Palliative Medicine. So to discuss how we die has changed forever, I'm really pleased to introduce David.
Thank you very much for the warm welcome. I too would like to acknowledge the Ghana people and to pay my respects to their elders past and present. As custodians of the land on which we meet today, custodians for millennia before us. When we talk about death and dying, it's not necessarily all bad news. I remember sitting in clinic one Tuesday afternoon. I remember it well. This is a woman that I had seen on several occasions. She had head and neck cancer. It was nasty disease. She came in that afternoon and clearly something was different. I said, "What's changed?" And she looked at me and she kind of sized me up before she finally said in that dreadful voice that she had left, "I've beaten the bastards." I said, "What do you mean?" She said, "Do you realise, David, I can't get parking tickets. I don't have to pay the phone bill. I don't have to pay the rent. They can't touch me." What did she do with that? She did something really special. This is a woman who, long before our current social security system, had raised 5 kids under the age of 7 single-handedly. She'd never had 2 cents to call her own. And so rather than pay all those bills, she flew her family in from the corners of Australia, from Broome, from up in North Queensland, while she was live enough and well enough to enjoy. I saw her the week after that particular weekend. I said, "How was it?" She said, "I can only remember till about Saturday afternoon. And after that, it's a bit of a blur, but it was a great party." And so she said the things that she had always wanted to say to her kids. How much she loved them, how proud she was of them, how much they meant to her. Most importantly, it gave her the opportunity to have conversations that you and I probably don't have frequently enough. And so as we think about that, we need to think about how our lives have changed. They're my disclosures, although none of them refer to this afternoon. I want to start this afternoon and finish it with Oliver Sacks, who very sadly died a couple of years ago. And with warning of his death, he started to write, and he wrote a book of essays which built on his enormous oeuvre over a long period of time in communicating with the public. There will be no one like us when we are gone, but then there is no one like us, like anyone else ever. When people die, they cannot be replaced. They leave holes that cannot be filled, for it is a date, the genetic and neural date of every human being to be a unique individual, to find his own path, to live his own life. That was part of his peroration on life, and I think it bodes well for a conversation this evening about how death has changed. We will be talking about large numbers this evening, but I want us to remember that each of those numbers is made up with the life experience of individuals, of a large number of individuals who, importantly, when aggregated, give us the sort of pictures about which we'll be speaking this afternoon. Let's not lose sight of each of those people. So our life expectancy has changed pretty dramatically over the last century. In fact, in the history of humankind, never has there been as rapid an improvement in life expectancy in a community. So if we go back to the turn of the 19th into the 20th century, I'm actually past my use-by date. And my chances of being alive were really not that great, even in the few years past that use-by date. Look at the changes across that century. So that someone born in 2013 as a woman in Australia has a life expectancy that will surpass 85. That's really a massive change for our community. And so it has framed the way that we die. Those changes are spread right across the century. Those changes have been occurring year on year across that period of time. And when we think about why that is, it's actually some very, very simple things. Predictable clean water. Predictable nutrition. And when we think about predictable nutrition, we see fascinating pictures 40 years after the Depression where, in fact, the upward gradient takes a slight detour. Vaccine-related therapies that have made an enormous difference to infant mortality across those years. And then the real advances from World War II onwards that have really taken acute care to a new level. But much of this was within grasp with very, very simple things. Water, nutrition, and vaccines. And we do pretty well as a country. Our life expectancy it ranks third in the world behind Japan and Switzerland, and for males ranks third in the world. What you don't see on this slide is probably more important, as we'll see in a couple of slides' time. What we don't have here is, for example, the United States of America sitting right up here. And if we take it not to just be mortality, but to also consider disability-adjusted life expectancy, then we're still right up there at the top of the rankings in the community in which we live. And if you have a spare moment and wanted to explore something new, go to the Australian Bureau of Statistics actuarial life tables. Great reading, scintillating stuff. But it is. If you make it to the age of 70, you've done away with a lot of your competition. And so the good news is that if you make it to 70, your life expectancy in Australia today is 18 years as a female. It's still 15.6 years as a male. And if you make it to 90, more of your competition has disappeared. And really, you've got a life expectancy that is still measured in several years. That has huge implications for our lifestyle choices and for the health care that we need to provide across our community. I thank the ABC for a very unique way of looking at this. What's the basis of by-elections over the last century? What we see disappearing here are deaths in office. And what we see replacing that, a lot of resignations. At the end of the day, the way we live, the way we die, has fundamentally changed. So, as we think about that, I want to apologise to Joanne Lynn from the RAND Corporation and just have a little bit of audience participation here. Who wants to die of cancer? Who wants to die of heart disease? Okay, I've got some takers there. Thank you. Who wants to die of respiratory disease? No. Breathlessness, as the good professor has pointed out, is an area of research interest, and I don't think any of us would want that. What about end-stage renal disease? No. End-stage hepatic disease? Neurodegenerative disease? So the rest of you are committed to dying of dementia and inanition. Because frankly, ladies and gentlemen, you've got to choose something on the table. The death rate in humanity so far, and we can argue the toss over a glass of bread any time, is still sitting at 100%. And so you've got to choose something. And what we see here is, again, that cancer in that dark purple line down the bottom is actually starting to edge down at a population level. These are the rates, not the absolute numbers. If we look at infectious diseases in the green dotted line, they really did disappear in the early half of the 20th century, so that they're now right approaching the asymptote. And although the US Surgeon General denies it, there is a document in 1967 which says within our generation we will have dealt with infectious diseases. We will have cured infectious diseases. Now, it's difficult to find chapter and verse for that, but it is interesting to think about it. And look at cardiovascular disease, circulatory diseases as it's called on this slide. What a fantastic outcome. To see that peak in the mid-20th century, to have built whole health systems around that, and to see the decline as we've actually addressed lifestyle issues is a massive step forward. And so at the end of the day, the challenge for us is that we have fundamentally changed how we die. If you just take the first half of that graph and think about what that looked like in the community, with people frequently dropping dead in their fifth and sixth decades unexpectedly, if you take it to the first quarter of that, with infections that were causing death that we wouldn't even turn a blind eye to today because they are just not part of what we see, then the challenge is, from what do we die? And there's a perversity in this. If we're talking about the rates of cancer across our community, we're talking about those rates because we live long enough to get it. What's the biggest single risk factor for cancer in our community? Having birthdays. And if we can cure having birthdays, we'll cure cancer. It's as simple as that. And so with that, we have changed forever what... I'm going to disable whatever that says it is. Whatever we have. If we look globally at health, Australia is in the second highest stratum here for our expenditure per head of population per year on health. And despite that investment, you can see the countries in dark blue, Norway, Denmark, Switzerland, Iceland, and the United States of America. And only Switzerland of those countries appeared on the tables that we've already seen. So it's fascinating to think about the relationship between healthcare expenditure and indeed health. Now, as we look to the future, the future may not be quite that bright. There is a theory out there that, in fact, we've seen the generation who has the longest life expectancy. And the beautiful thing for Australia is we have a crystal ball. It's called the United States of America. And we can look into the future with absolute confidence by looking at what's happened there. So this is a picture of the United States, and it does have Hawaii and Alaska down here on the left-hand side of the slide. It's got all of the states. And you'll notice that there are three categories for adult obesity in 1990. There are three categories, three colours that we see, including the grey, where they haven't actually really made the big league. But by 1995, that had changed. But then, from 2000, you have to start adding categories. And so we add 20 to 24% and see that essentially, by population, this represents about 80% of the population of the United States. We've got to add another category in 2005. We've got add another category in 2010. And if you really want to be distressed by this, you've got to add another category in 2013. So as we live, we make lifestyle choices. And we've made some really smart lifestyle choices in the last century to get an unprecedented growth in our life expectancy, but at a time that we have the best access to nutrition ever in the history of humankind. You know, we now have the choice of several thousand parts of a staple diet. We're still making some very strange choices. So Leanne Donaldson, as the Chief Medical Officer for England, gave us 10 tips for better health. Nothing terribly radical about any of those, but a really interesting thing for someone in such a senior role to take forward. Keep physically active, manage your stress. If you drink alcohol, do so in moderation. He didn't say practice safe sex, he said practice safer sex. A wonderful reality about that. Be safe on the roads and follow the highway code. Wonderful admonition for us all. A little later, there was a response to this. And it was a response called the Alternative 10 Tips for Better Health. And what it spoke to was the enormous social inequities across our community. Because those social inequities define in so many ways the health that you and I and the communities in which we live enjoy, or indeed don't enjoy. And those socioeconomic disparities also have a massive impact on how we live and ultimately how we die. What do I mean by that? Well, you know, we've got disparities in health literacy. And even our most advantaged communities, the top 20%, that top quintile, only just has half of the people who have enough health literacy to actually navigate the health system in which we live. If you go to the lowest quintile, then dramatically that drops even further, so that it's about 1 in 4 people have enough health literacy to navigate the health system around which we live and work. That's a huge challenge as we try to actually improve the health of a community. And sadly, those socioeconomic differences are still there when we die. So from Australian data, and again, Professor Bird mentioned the Palliative Care Outcomes Collaborative, when we actually looked at that by postcode and the physical availability of services, we got some really interesting pictures. Again, for the most advantaged of our community, later referral to palliative care. Significantly less likely to be referred at all, and if you are an inpatient, to have inpatient care for longer periods of time. By contrast, the lowest quintile postcodes had the least likelihood of being close to a physical environment where inpatient care could be provided. So even in death, our socioeconomic disadvantage shows its head yet again. So what I'd like to do in the time that we have together this evening is think about the changes in how we die and how that affects every person, their caregivers, and ultimately the health system in which that care is delivered. So as we think about every person in this setting, what is it that we need to consider? Most of us in this room will have warning of our death. Not by hours or days, but by months or even years. Again, in the history of humankind, unprecedented. And so the question is, what are the conversations that we should have in that setting? I was in clinic and a man came to see me for the first time. He, interestingly, had been referred directly from his general practitioner and hadn't seen an oncologist. And he had a cancer where chemotherapy was likely to make a substantial difference not only to his life expectancy, but also to his quality of life. And I said to him, I really think you should see an oncologist. And he was getting more and more agitated through the consultation. And finally he said to me, why are you wasting my time? And I said, I'm sorry, I had no idea that you felt that way. Why do you say that? His frame of reference was only 3 people in his life had had cancer. And all of them had died within 4 weeks of telling him. Here I was on a beautiful autumn afternoon, wasting one of those precious 28 afternoons that he had left. The beautiful thing is that he, after a long conversation, did decide to see an oncologist and got a really great 2.5 years as a result of some therapy. In that 2.5 years, he had his 80th birthday. And again, you know, you and I can, at times, unfortunately, make value judgments that have no basis whatsoever. He lived in a local caravan park. His daughter drove past the front gates of that caravan park every single day. For his 80th birthday, she didn't come in to say hello. But at 4 o'clock in the afternoon, he got a knock on the door, and it was his neighbours. They'd had a whip round. They got a cake for him, and they knew that the one thing that was on his bucket list was flying in a biplane. And so they bought him a joyride in a biplane. And what a fantastic outcome for him. He was able to, with warning of his death, actually make the most of it, with a bucket list that was fulfilled ultimately by people he hardly knew, but who reached out to him and said, you're special and we want to acknowledge that. You know, that warning is often our opportunity to do something very special. If you're only awake for 30 seconds this evening, this is the 30 seconds. That conversation about prognosis is really, really important. And I'll be honest, many of my colleagues do everything they can to avoid that conversation. But the angriest people that I have ever seen are those who feel that they have been robbed of time. That someone, one of their clinicians, knew that their number was coming up and had not had the courtesy to have that conversation so that they could prioritize things that were really important to them as they faced the end of their life. That anger is justified. That anger is understandable. And that anger, as we change how we die, is part of a conversation that we need to change at the same time. Robert de Say wrote this as he travelled through Italy at a time when he knew he was not only HIV positive, but if my recollection is correct, that he actually had been diagnosed at that time with full-blown AIDS. And it was just before triple therapy became available, and he has been one of the great success stories of that. But he said the trick is neither to hope nor to despair, but to be alive now. And perhaps a century ago we were better at doing that because death was around every corner and life was so unpredictable. Now we get some warning of our death. We probably have to change that conversation. Joey Clayton has done some really great work in this space. She's recorded consultations between clinicians and patients having really difficult conversations. And one of the things that comes out of that consistently is the ability to simultaneously hold hope and acknowledge reality. Patients are good at doing it. As clinicians, we're just afraid in having those conversations. So as we think about that, or not, I'll be back soon. Or not. As we think about that, thank you, Kendall. As we think about that, the issue is that patients are able to do that and do that incredibly well. And so we have to trust their resilience, their skills, their ability to indeed do that. So with that in mind, the question is, what is important at the end of life? And the short answer is, thank you so much, that's fantastic. The short answer is that we need to be smarter. Now, diagnosing dying by the presence of rigor mortis is like diagnosing pregnancy at birth. It happens, but there are clear pointers for most people. With that, we need to think, what are those pointers and what are the conversations that need to occur as a result? In order to answer that, I want to take a step back and ask, why do we die? And that may seem like it will have self-evident answers, but let's just think about that. Whether it's cancer, HIV/AIDS, end-stage organ failure, neurodegenerative diseases, what is it about these things that actually causes our death? So the body is really good at trying to maintain its current status. It's one major goal. And so it goes into overdrive when it's challenged. And what we see is a final common pathway. A common pathway which is characterized by weight loss, by loss of appetite, and by incredible fatigue. Fatigue that is not relieved with sleep. Weight loss that is not reversed with nutritional support. And importantly, a loss of appetite, which is a bit like you or I with a really bad flu. Not only do we not feel like eating, but if we do eat under those circumstances, we actually feel worse. There's nausea and a feeling that's very uncomfortable. So it's not that people lose appetite and lose a will to live in that space. Even the studies that were done, and admittedly they're 30 to 40 years old, of total parenteral nutrition, the right balance of protein, of calories, of vitamins, of minerals, not only didn't see benefit in this setting, but at that time saw excess mortality. And so, as we come to a clinical setting, one of our challenges is death a failure? You know, it's really easy to make headlines in this country. A doctor who makes a terrible mistake that causes morbidity or mortality is going to be on the front page. And we think about that, and so we should. But by contrast, almost all of the deaths in our community are not through misadventure. They're not because someone stuffed up. They're because this was the outcome that was going to occur. And we may be able to change that somewhat. But in advanced cancer, in advanced AIDS, in advanced end-stage organ failure, we are playing around the edges. And we need, as a community, to have that as an honest conversation. So we need to differentiate someone who's dying as a result of a life-limiting illness with intercurrent problems. You know, did this person die of pneumonia? No, actually they died of advanced cancer. Yes, they had some pneumonia, but if you or I had that pneumonia, it wouldn't touch the sides. And we need to be really clear about that. And yes, there are people who die prematurely even in the setting of a life-limiting illness, and we need to recognize that, and we need to understand it. But at the end of the day, we, in doing that, are understanding better why we die. And to look at data that we've published recently with a group from Western Australia, where we had consecutive data on more than 6,600 patients, 48,000 data points, where community nurses, as they saw patients, said, "So how are you today? How's your fatigue? how's your pain, and in this case, how is your breathlessness. On the z-axis here we have, and I really didn't do anything there, hands above the table. On the z-axis we have the last 3 weeks of life going away from you and from me. On the y-axis we have their breathlessness scores, and on the x-axis we have 4 groups. Those on the far left are those with a very poor function. They need a lot of support on a day-to-day basis, intensive nursing care, and importantly, also have no documented cardiorespiratory disease. And we go to those with a better level of function and no documented cardiorespiratory disease in those next 3 columns. In the next 3 columns, we've got the first group of people with documented cardiorespiratory disease. And they're still not functioning really well. They need intensive support on a day-to-day basis for the activities of daily living. But this group on the right-hand side are of particular interest to us this afternoon, because they're people with documented cardiorespiratory disease, a good level of function. Not fantastic, they're not like you and me this afternoon, but they're still providing some of their own care. They're probably able to shower themselves, feel a bit tired at the end of it. And what happens in the week immediately before death is that they start to complain of markedly increased breathlessness. So even in that process we've described this afternoon of the body slowly closing down, which is the normal pathway for most people in these settings, we've got signal here that there may well be factors that are suddenly exacerbating their breathlessness, and the more sudden the change, the more likely there is to be at least an identifiable cause for that. Whether we choose to do something about that cause would be in consultation with that patient and their family. So that group do tell us that not all pathways are the same, even in this setting. So the deaths we're talking about are rarely due to malnutrition, dehydration, and generally not due to simply a single organ failure. They're far more complex than that. And so in thinking about that, in thinking about the warning that the body gives us, what is important at the end of life? 2 studies on which I want to reflect. The first is by Peter Singer, not the ethicist, but a clinician from Canada, who interviewed people with a range of illnesses: end-stage renal disease, advanced age, and AIDS. 5 domains were consistently identified, starting with pain and symptom management as the first and most important domain. This concept of avoiding the prolongation of dying was really important, and the next 2 go together strongly, that sense of achieving control and relieving burden. We've been really good as a community since about 1950 at prolonging dying for many people, where we're not going to change their prognosis by more than a few days or a few weeks of potential misery or indeed real misery. And how many decisions are driven in our community because of a fear of being a burden? Not being a burden, but the fear of being a burden. Who of us in this room tonight is looking forward to the first time we have to ask someone else to help us to the bathroom, knowing that every time we go to the bathroom from here on, we will need that help? And so, as we think about that, Karen Steinhauser did some work which was published the year after, and this really is a seminal study. She sat down with focus groups of people not from Rundle Mall, but people who were actually facing their own mortality in the coming months. They'd been told their prognosis was limited, and so they were asked what's important in that setting. It was a national cross-sectional random survey that she conducted. 4 groups were surveyed: patients who had been told that their prognosis was measured in months, recently bereaved family members 6 to 12 months after the death of someone close to them, doctors who looked after people in that setting, and other healthcare providers. Again, my hands were above the table. A wide range of diagnoses, so this wasn't a single signal that we would be getting. There were domains for which all 4 groups, with a very high response rate, agreed. Preparation for death was important, achieving a sense of completion. You know, I said to one person, time's pretty limited, what do you want to do? He said, my tax returns for the last 4 years. And I thought, you poor bugger. But he was really serious. He said, the one thing I cannot leave for my wife and kids to do is the tax returns. It's unfair on them, and if I can do that, then I will have achieved what I need to achieve in order to die happy. We've all got different things on that list, and we need to listen to people in that setting. Being involved in decision preferences and being treated as a whole person, one has the sense that people don't feel that they are treated as a whole person if they need to put it right at the top of their list. When you looked at the priorities for patients, caregivers and health professionals, symptom control and personal care were there. And I want to separate those. We run them together so easily. Symptom control was important as an avenue to do other things. And so it was an enabler to ensure that people could prepare for the end of life, achieve a sense of completion, be consulted about treatment preferences, and be treated as a whole person. But that personal care bit we forget too often. Our health system, as with health systems around the world, invests far too little in allied health. And it invests way too little in allied health for people late in life. This is not necessarily about rehabilitation, but as one of my PhD scholars put in her thesis, habilitation. How do you get a body that is no longer predictable and that may fail at any moment and make the most of that? To make sure that you can still transfer from bed to chair or chair to bathroom and back, and actually provide the skills up front so that that can happen. And we'll return to that in a few moments. The thing I really love about this study was that the things that patients thought were important weren't there for lots of other people. So maintaining a sense of humour. How many patients responding thought this was either important or very important? Anyone want to start the bidding? Come on, pick a number. All of them? Wow, that's a hell of a number. That's 100%. Okay. Anyone want to go down from 100% at all? 80? 80? If we went in the middle of that, we'd be absolutely right. 93% of patients said it was either important or very important to maintain their sense of humour. Who hasn't used humour as a coping mechanism? Who hasn't, after a really hard week, gone home and watched an episode of Big Bang just to feel a bit better? Why would we suddenly lose that simply because we have a life-limiting illness? And again, not being a burden. Being mentally alert at the cost of other symptom control. That caveat's really important. And what isn't on the list, they didn't care where they were at the moment of death, as long as they had family and friends around them, because that was what defined home. By the way, how many doctors thought it was important that people maintain a sense of humour at the end of life? Well, thank you. Who said that? Haig's chocolate frog for you, sir. Right on the money. And what about nursing staff? 63%. So this not being a burden is a real driver in people's minds. How do you and I, as members of the community, or as health professionals, make sure that people don't feel that they are going to be a burden? How do we create an environment, a community discourse, that ensures that people don't sense that? And then there are the things that Peter Maguire, the father of modern psycho-oncology, a psychiatrist from the Christie in Manchester, put together. And his list includes the things that patients will never or rarely volunteer, but they expect a compassionate, competent health professional to raise those topics. relationships, self-identity, sexuality, intimacy, financial burdens. These are the things that people still want to talk about at the end of life. How many patients have I seen who say to me, I just want someone to hold me? That intimacy goes. And as a community, as we see someone who is labelled with a life-limiting illness, we don't know how to react. We need to learn new language. We need to learn new ways to engage and provide intimacy as self-identity changes. I've seen people who don't recognize themselves in a mirror. They don't know who just walked past that mirror. Their body has changed so dramatically. And so self-identity is threatened in this. Relationships are challenged in so many ways. And as a community, we need to learn a new language for a new way of dying. We do with functional status what we did with pain 30 years ago. We say, of course you're getting weaker, you've got a life-limiting illness. But what if we could change that? This is the Karnofsky Performance Scale. David Currow was a medical oncologist at Memorial Sloan Kettering, and in the 1950s he put this scale together. Hopefully you and I this afternoon are 100, but it's also an honest scale because although the slide cuts it off, it goes down to 0, which is dead. And importantly, at that level of 70, you start to need help from other people. Now, what if that was a typical trajectory at the end of life? Function on the y-axis, time, unfortunately the wrong way round, on the x-axis. What if we could change that trajectory? Haven't changed the moment of death by 1 single second. But what if we could change the functional directory so that the time that you were fully independent in your activities of daily living went from that to that? That fits with that priority that patients themselves have said is crucial to them, the ability to care for oneself for as long as possible. What about their caregivers? This is a whole-of-community issue. From South Australian data, which we collected from 27,000 face-to-face interviews, we went looking for people who had had someone close to them die from an expected death, a terminal illness, in the last 5 years. 1 in 3 people had someone who fulfilled those criteria. 1 in 10 people said they had provided care in that setting in the last 5 years. And 1 in 30 people said they'd provided intensive, day-to-day, hands-on care. Multiply that out across our community. This is something that we are likely to do more than once in our lifetime. And as our life expectancy increases, so will our opportunities to do that. Caregiving is a health hazard, however. Excess mortality both while in the role and in this hangover period of at least the first couple of years after the role is completed. This is not for the faint-hearted. And unfortunately today, we just expect that people will be a caregiver, that spouses will say, well, it's my duty, when in fact they may not be physically able to do it. Or that with a little additional help they can. In some commissioned work for the Australian government, 7 to 9% of Australians facing a life-limiting illness could not identify someone who would provide care for them when they needed it. That's a big group in a community. This is a whole-of-community issue. And we were brave enough to ask the question, so you've provided care, would you do it again? I think we were the first group in the world to ask that at a community level. And what was the answer? Generally, and wonderfully, it was yes. But 7.4% of people said, absolutely no way would I do that again. And another 16% said, I'm not sure that I would be able to do that again. 1 in 4 people either wouldn't or were undecided about their ability and interest in doing that. And so we need to ask people not only would you, but are you able to provide care in that very challenging setting? And increasing age and educational levels were both predictors. So what does that mean for our social and health systems? I'd like to suggest that people no longer die in our acute care institutions. They have cardiac arrests. It's really, really hard to die in hospital. People come and jump on your chest, and people ask awkward questions like, do you want everything done? And what the poor young doctor's asking is, do you want resuscitation? And what the family hear is, do you want everything done to keep your grandma comfortable? And they go, yes, of course we do. And the doctor goes, they want resuscitation. And we've got this huge, huge chasm in communication. And so again, we're back to distinguishing between death as a failure and death as an inevitable outcome. So we have to distinguish between expected and unexpected deaths. In the words of Margot Somerville, we need to distinguish between futile and clinically futile outcomes, interventions. And clinically futile is absolutely objective. If you have a cardiac arrest on Rundle Mall, your chances of walking out of hospital are about 1 in, I can't remember the number, but let's choose it, somewhere around 14,000. That's a very objective figure. So clinical futility becomes very easy to define in that setting. So if we provide good care for people as they face a life-limiting illness, what can we do without compromising survival? We can reduce hospital admissions by 25%. Who wants to spend more than a moment in hospital that they have to? None of us that I can think of. Reduce the number of inpatient bed days and reduce costs compared to conventional care. So in South Australia, we ran the world's largest randomised trial where we consented both the patient and their general practitioner, and said if we bring the general practitioner, the patient, a community nurse together just once, and whoever else they want to bring, just once, will that have an effect on health service utilisation? By God, it will. So you only needed a minimum of 3 healthcare providers, 15 minutes, didn't even need to be in the same room. Could do it by teleconference as early as 2003. There has been a funding stream under the Medicare benefit schedule for this since 1998. And so at that time, our whole service set out to become engaged in it. And 461 people were consented. As a very brief aside, when we did the pilot, we consented the general practitioners first, got a 63% response rate. So when we did the study itself, we consented patients first and then went to their GPs and said, your patient has consented, would you like to be involved in the study? And we got, as you can see, a 92% response rate. Now back to function and back to that same graph, same table we had of Karnofsky. One case conference changed that functional status over time by about 8 points. What's that the difference between? That's the difference between being relatively self-caring and relatively reliant on others. Biologically plausible? Absolutely. Because these 3 people have to talk. They're a virtual team, but they're also a team that comes together just once around this patient. And so to get a few things sorted out in the house, to get a few rails so that people are safer, to maintain the mobility that people have, yes, this is biologically plausible. That we can change the shape of that graph with simple, funded interventions. What's the rate of uptake of case conferencing 5 years on from publication of those results? Hasn't changed across Australia at all. And in the Medicare benefit schedule review, who knows whether that will actually stand the test of time. What about hospitalizations? We reduced hospitalizations significantly in that time, not only statistically significantly, but really clinically significantly for patients. You engage primary care with tertiary care services, you engage patients and their caregivers in a conversation, you make a difference. And that's exciting to know, but the question is, how do we do something about it? It gets better and better. I'm not going to touch anything because my hands weren't above the table that time. Oh, well done. that also had direct implications for how we designed and worked on our service. Ultimately, the way we die has changed. It's never going to go back to the way it was at the beginning of the 20th century. We as a community have to develop new language, new ways of supporting people, new ways of reaching out to those members of our community who face life-limiting illnesses. We need to be aware of caregivers and the challenges that they face in their own health, in their ability and willingness to undertake this intensive care. And we need to think about not only the health systems, but the social systems in which we work if we're going to support people at this very challenging time in life. I leave you this evening with the words of Oliver Sacks. I cannot pretend I'm without fear, but my predominant feeling is one of gratitude. I have loved and been loved. I have been given much and I have given something in return. I have read and travelled and thought and written. I have had an intercourse with the world, the special intercourse of writers and readers. Above all, I have been a sentient being, a thinking animal on this beautiful planet, and that in itself has been an enormous privilege and adventure. As we face the 21st century, how are each of us going to make a difference to the people in our communities facing life-limiting illnesses? I'm happy to take some questions or comments.
Thank you, David. Questions? Yes, please.
More of a comment. I'm an anaesthetist, so in the public hospital, my name's Richard Lee. I have a lot of problems with using the expression futility in care. I think it's very easily misunderstood by both patients and their families. I much prefer to talk about having a good quality of life and a good quality of death. Mm-hmm. And make it clear to the family that there can be some interventions that are done that will produce a very drawn out and very unpleasant quality of death. And it's something that we see all too often. A number of patients who've got advanced dementia who get referred to us so that we can sedate them in the hope of them having a peg put in because they're having trouble swallowing. They're not communicating anymore. They're stuck in bed, confined to bed. An aspiration and pneumonia following it would probably be a pleasant way to die. I don't know whether you have a strong feeling about that.
So that's why I make the distinction between futility and clinical futility. If there is an objective measure that says you have a 20% chance of aspiration from this and a 3% chance of aspiration without it, that may well be clinically futile if that's not going to improve either the quality of that person's life, their symptom control or their function. And if it's not going to do one of those three things, then I think we do need to have an honest conversation that says this is clinically futile. That is, there is an objective measure, as opposed to futility, which is very subjective, and I agree with you entirely in that. As a community, we have not had those conversations nearly often enough. And we continue to do things to people, and I choose the words carefully there, do things to people without their consent and without full knowledge either of that person or their family on the alternatives that are available to optimize their comfort and their function in the circumstances in which you've outlined.
Other questions? Perhaps I could take you back. You referred to a big issue, big societal issue around health equity, or rather inequities. And I think you hinted that this is, if anything, an even bigger issue in the palliative care, the end of life. Could you say a little bit about just that, those differences depending on where you are and your, where the society, the place in society?
Yeah. Thank you. I mean, I think one of the challenges is that when you start to drill down, you see that the postcode lottery is alive and well, and the services that are available are quite different. Within the private setting nationally, very few large private hospitals offer palliative care. And yet you and I may well be paying private insurance thinking it covers us from the cradle to the grave. The reality is that those patterns of referral are demonstrably different to people who have are more socioeconomically challenged. In the socioeconomically challenged communities, interestingly, the physical distance from clinical care is far greater. The likelihood, therefore, of community-based care being a reality and able to see people through to care for as long as possible at home is incredibly limited. And if we think about those crescents, the crescent in the west of Sydney, the west and north of Melbourne, the east of Perth, the north of Adelaide, these are areas that are traditionally very poorly serviced in community care and in primary care. And, the big predictors of home-based care sit with a caregiver under your own roof, and primary care that is going to support you around the clock. And without those two things, the reality of community-based care is extremely limited even today.
Thank you. Any other questions? Yes, please.
Hi, really interesting talk. I wanted to ask a question that people have very mixed feelings about, which is, how do you think that euthanasia comes into these conversations about improving the quality of death?
Yeah, look, euthanasia is another topic altogether than tonight's topic. I think the important thing is that it requires a sophisticated conversation in our community to understand its benefits and its burdens. It's very easy to make the case on an individual basis, to say this person is suffering and this is something that can be done for them. At a community level, I note that the parliaments of Australia at a jurisdictional level, with the exception of the two territories, the House of Lords repeatedly has stepped away from this. And it does have societal consequences. The one thing I would refer you to is the Department of Health and Social Services in the Netherlands, who are required under their current scheme to report annually the number of people who are euthanized who were not party to that decision. And that's a 4-digit figure every year. So as a community, we need an honest conversation about the pluses and minuses of that, with the very great realization that it will change our community. Whether we think as a community that's for the better or worse, that's the public discourse that has to occur, and it needs to occur away from individual decision-making around example cases.
Yes. Perhaps one last one. Yeah.
So just wondering, how can this increasing the quality of death be, and strategies to do so, be transferred into residential aged care facilities where there is a high prevalence of a lack of cognitive ability?
So in terms of residential aged care, there are a lot of initiatives going on around Australia and indeed around the world to work with aged care facilities, with their staff, and particularly with families and clients around the time of admission. And I think those early conversations that are honest, that seek the values that will help determine how a person or their surrogate decision makers will move forward, are really important conversations. And we've got great examples in Australia where we've got residential aged care facilities where that's part and parcel of the care that they offer. Understanding the values that you would have were you to face this challenge compared to someone else here tonight is crucially important, so that those values can be respected and indeed upheld. I think we've got some great examples where residential aged care facilities are at the very peak of quality care in that regard, and others that have a long way to go in order to catch up.
Okay, I think we'll need to draw it to a close. So just to thank you, David, for a thought-provoking, sometimes moving, appropriately challenging presentation. I think you've given us a healthy approach to the inevitability of death. So thank you very much for that. And I'd like to ask you all to thank David for a wonderful presentation. A very small token of our appreciation. And again, thank you all for coming. We hope to see you in future elections. Thank you very much. Thank you.